Good evening, everybody who are watching this program from India, and good morning to those who are watching it from Brazil. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Leandro Alves de Oliveira from Goiás, Brazil. Dr. Oliveira is an orthopedic surgeon specialized in hip surgery. His primary activities are hip preservation, pelvis and acetabular trauma, and hip replacement surgeries. He leads the hip trauma department in the emergency hospital of Goiânia, and he's also the coordinator of orthopedic surgery service of the General Hospital of Goiânia and hip surgeon of the Federal University of Goiás. He's been the former president of the Middle West region of the Brazilian Hip Society, and he's currently the president of the region Goiás of the Brazilian Orthopedic Society. So today, it's my great honor to introduce you to Dr. Leandro Alves de Oliveira for this fantastic live program. Over to you, Leandro.
Okay, first of all, I would like to thank Dr. Hitesh Gopalan for this invitation to give this lecture and say that it's a pleasure and an honor to take part of his continuous education program. So, my name is Leandro Alves de Oliveira. I'm from Goiânia, a city in the middle of Brazil, near Brasília, the capital. And these are the hospitals that I work here in Goiânia. The COT is a particular private hospital, and the General Hospital of Goiânia, public service, and also the Federal University of Goiânia, and the UGOL, that's a hospital only for trauma. So I don't have no potential conflict of interest for this lecture, and we will talk something about the ischiofemoral impingement. I will give a soon introduction about this disease and also do the definition and the pathological anatomy of the ischiofemoral impingement and its clinical presentation, its radiological findings, the therapeutic strategies for the treatment of this disease, and some messages to take home. So the ischiofemoral impingement was first described in 1977 by Johnson in this article that he observed that some patients who underwent total hip arthroplasty or valgus osteotomy of the femur, they reclaimed pain in the buttocks after the surgery, and he noticed that these patients had a narrowing of the ischiofemoral space even after the total hip arthroplasty or the valgus osteotomy of the hip. So the ischiofemoral impingement is a rare entity. It's not very common. It's more often in the female patients. We can find some typical changes in the MRI and in the radiography. Just we can see in this picture, the entrapment of the quadratus femoris muscle in the ischiofemoral space, the edema, and even sometimes degeneration of the muscle. We can have secondary causes for the ischiofemoral impingement, as we can see in the picture, and osteochondroma in the lesser trochanter. And every time we have a patient with buttocks pain, we have to think about the ischiofemoral impingement as a different diagnosis for the piriform syndrome, the hamstrings lesions, and even the sciatica pain. The ischiofemoral impingement is a syndrome, and we must have the presence of typical symptoms in the buttocks. The physical examination finds that I will comment about it posteriorly in this lecture, and in the imaginologic exams, we can see the narrowing of the space between the ischium and the lesser trochanter with the entrapment of the soft tissue represented by the quadratus femoris muscle. And the ischiofemoral impingement can have secondary causes, just like the coxa valga we can see here in this picture. The osteoarthritis, especially which we have the proximalizing of the femur, sequelae of Pertz, also osteochondroma, again that picture, and can be caused by iatrogenic causes, just like after total hip arthroplasty or valgus osteotomy of the hip. And we can have functional factors causing the ischiofemoral impingement, just such as the weakness of the abductor muscle. The symptoms of the ischiofemoral impingement is very typical. We have gluteal pain that in the beginning is very weak, and they become worse and chronic. Sometimes the patient looks for the doctor after 1 year of symptoms, and sometimes it can mimetize sciatica, and the patient can observe snapping and clunk sensation in the posterior part of the hip. And the pain gets worse with the hip extension. Some typical findings in the physical examination, the test of choice is to do the passively extending, adducting, and externally rotating the hip, and the patient reclaims pain in the buttocks. And when we do the passive extension and internal rotation, we do the stretch of the quadratus femoris muscle, and the patient also reclaims pain in the buttocks. Gomes-Royos described two tests for diagnosis of the ischiofemoral impingement. The first one is the long stride walking test. Patient does a long step, he reclaims pain in the buttocks, and there is the IFI test that we do a passive extension with adduction, and the patient reclaims pain in the buttocks, and then when we do the passive extension with abduction, the pain gets better. In the simple radiography, what we can find is the narrowing of the ischiofemoral spacing, and also in chronic cases, we can see cysts in the ischium. But the best exam to assess the ischiofemoral space is the MRI. In asymptomatic patients, the length of the ischiofemoral space is 18 to 26 millimeters. In the symptomatic patients, this length is thinner than usually it is. And we can evaluate the soft tissue represented by the quadratus femoris muscle, and also less trochanter retroversion, and sometimes we can observe if the patient has intraarticular pathologies, just like the labral tears and chondral lesions. To talk about the treatment, this is an article written by a German group, where they did an algorithm and a revision of the literature of the best way to treat and to address the ischiofemoral impingement. So when we think about the treatment, the first option is the conservative measures using non-steroids anti-inflammatories with physiotherapy, aiming the strength and the stretching of the quadratus femoris muscle and the external rotation muscles. If the patient has symptoms that mimetize sciatica, you can use gabapentin to improve the pain. Another way to treat this is using ultrasound or CT guided infiltration. Here in our service, we do this infiltration guided by ultrasound. This is a video given for me by Dr. Morris Joseph. He is an orthopedic surgeon here in Brazil who does a lot of infiltration. So we can find the ischiofemoral space and do this infiltration just like we can see in this video. So we have here the gluteus maximus, here is the sciatic nerve, the quadratus femoris muscle, here is the ischium, and here is the intertrochanteric line. In this other video, what we can see is the needle in the quadratus femoris muscle, and we are injecting the solution with lidocaine and corticosteroids, and the patient gets better of his pain. In this German group, they do this infiltration guided by CT. different of us that we do it guided by ultrasound. When the patient don't get better with the conservative measures, we can indicate the surgical treatment. We have especially three approach for the surgical treatment. The first one is the open resection that they do a lateral posterior approach for the hip and does the resection of the lesser trochanter with good results. Another approach is the posterior arthroscopy resection, just like described by Hatem in this group. He does an arthroscopic to hip pathologies intraarticular, and then he, at the level of the last trochanter, he does a third portal, and this is what he see in these portals: the sciatic nerve, the quadratus femoris muscle, and he does the release of the quadratus femoris muscle, and he can observe and see the last trochanter here in this image. And he does only the partial resection of the last trochanter. He has an outcome of 2 years with good results and the good improvement of the pain of the patients in the buttocks. This is another approach, the anterior arthroscopy resection described by O'Donnell in Australia, that he does the last trochanter osteoplasty anteriorly in the arthroscopy, and he says the advantages of this is the low risk to neurovascular structures, technically simple, potential to address concomitant pain generators, and it is easy to obtain fluoroscopy images. The disadvantage is that inability to assess hamstrings and sciatica nerve. You do not assess the posterior part of the hip. The lesser trochanter is a posterior structure, so the anterior approach requires externally rotating the hip, and the risk to lateral femoral cutaneous nerve and femoral neurovascular structures. This is a patient of mine, a young lady, a 28-year-old female patient. She had pain in the buttocks for 2 years. The pain mimetized sciatica pain. She had already done use of medicine, physiotherapy with no improvement of the pain. So we decided and indicated to do the resection of the last trochanter by arthroscopy. She had the entrapment of the quadratus femoris muscle, narrowing of this space, and she was with much pain in this place. So we positioned her in the orthopedic table, just like this. Her hip, I maintaining the inflection, abduction, and the external rotation position. And when you use the fluoroscopy, when the C-arm of the fluoroscopy is in the vertical position, we see the femur in the lateral view. But when we position the C-arm in the horizontal position, we can see the femur in an AP position. And then I maintain the C-arm like this during all the surgery so that we can see the osteoplasty and the resection of the lesser trochanter, just we can see in these images. And in the end of the surgery, we removed all the lesser trochanter of this patient. Here is the video. We do the release of the tendon of the iliopsoas and the shrinkage of the soft tissue around the lesser trochanter, so we can do a good exposition of it. Just like we can see here in this video, doing the debridement of the soft tissue and the shrinkage. After having a good exposition of the lesser trochanter, we can start removing it. I like to remove it from the bases. I started doing this resection in the bases of the lesser trochanter, and we must have patience to do this, because when we reach the metaphyseal bone, it bleeds a lot. So, and if we put the pressure of the fluid very high, you can infiltrate the soft tissue around the thing. So we have to have patience and do calmly this resection. And I do the resection until we can see the bone here is flattened. So here we are performing this resection using the burr. So we have here the postoperative radiograph of this patient after 3 months, and she had a good improvement of her pain and a good function of her hip. Last year, during the Brazilian Hip Society, I published 4 cases that were 4 female patients. They had underwent lumbar arthrodesis for sciatica pain, but they didn't get improve of her pain. And when I evaluated this patient, we could see the narrowing of the ischiofemoral space, also cysts in the ischium, and the entrapment of the quadratus femoris muscle in the ischiofemoral space. I did the resection of the last trochanter in all 4 cases, and we have an improvement of the Harris-Hips score of an average of 52 before the surgery to 92 after the surgery. It was really a good improvement for these patients. So the message that I would like you to take home is that the ischiofemoral impingement is a rare entity, but you have to think about it when you have the different diagnosis for deep gluteal pain, especially piriform syndrome, hamstring lesions. The patient has to be carefully evaluated so that you can do some procedures that was not necessary, just like we see in these patients I showed the last. And you must know that the ischiofemoral impingement is a syndromic disease. You have the patient must present symptoms and physical examination positive, and also radiological findings. The conservative treatment is our first option with good results, and the surgical treatment is reserved when the patient doesn't improve with the conservative treatment, and we have good results in the surgical treatment. However, we have few articles, short follow-up in the literature, and few cases demonstrating these techniques to the patient. And I would like to thank Dr. Hitesh Gopalan one more time to the opportunity to give this lecture, and apologize if you couldn't understand the English I spoke very well. So thank you very much.
Thank you, Leandro. It was a wonderful presentation, and we could perfectly understand what you spoke. Just a few questions. Now,
Okay.
if you're doing hip arthroscopy for ischiofemoral impingement, what are the portals that you really look for? Is this the proximal posterior portal?
Oh, there are 2 techniques for the hip arthroscopy and the resection of the last trochanter in arthroscopy. I perform the anterior approach, so I do 2 portals, and both portals anterior. One is the traditional anterolateral portal, and the other in the level of the last trochanter, but I do it anteriorly. And the risk is the lesion of the cutaneous femoral nervus.
No, is it possible to go through a posterior portal?
Yeah, you
Posterior
can. Yes, there is an author that is Brazilian, Dr. Munif Hatem, that he showed in that article. He does it posteriorly. So in the level of the last trochanter, he does a portal posterior of the femur, and he can see when he does it the sciatic nerve and also the quadratus femoris muscle. So he goes through the quadratus femoris nervus, to do the resection of the lesser trochanter. He advocates that's better for the patient because you can do a partial resection of the lesser trochanter without doing the tenotomy of the iliopsoas tendon. He says that when you do the total resection of the lesser trochanter, the patient gets a weakness of do the flexion of the hip. That's true in the beginning, but what we can observe in the patients we did the total resection of the last trochanter is that after 6 months doing physiotherapy, he gets the same force as the contralateral hip to do the flexion.
Okay, thank you for that. And the advantage of a posterior approach is also you can do a sciatic nerve neurolysis, isn't it?
Sorry, I have some failure in the sound. Sorry.
No, the question I asked you is the advantage of a posterior portal would be that you can do a sciatic nerve neurolysis as well.
Yes, and there is some advantages. The first is you don't have to the risk of lesion posterior structures, just like the sciatic nerve, and also the quadratus femoris lesion, because we have the artery that supplies the head femoral head irrigation.
Okay. So how difficult is to get these portals? What is the learning curve for doing surgery for ischiofemoral impingement?
Yes, I think the most difficult part is to do a good positioning of the patient. So as you could see in my lecture, the positioning of the patient is not so easy because you have to do good flexion, good external rotation, and even abduction of the hip because the lesser trochanter is posterior. So you have to bring the lesser trochanter anteriorly to do the resection. And another, I don't know if you could observe in the images of the fluoroscopy, I used curves, bore that's curved so that I can assess better the lesser trochanter.
Okay, thank you for that, Leandro. I think, Leandro, that's all the questions that we have for this session. It has been a wonderful lecture, very enlightening. There's a lot of new insight into this particular topic. It is not a very common scenario to see ischiofemoral impingement, but you have really gone into depth about this particular disorder. Thank you very much for joining.
Once more, I would like to thank you and say that it was very nice to talk with you and with everybody who is in your channel, Orthopaedic Principles. It's thank you very much.
Thank you very much, Leandro. Let's end the meeting.